Right, hi everyone. So I will now talk about chapter 10, which is the management of pain and discomfort, and then go into first half of chapter 11, which is management of chronic health disorders. So in chapter 11, for the first part, I'll cover quality of life, emotional responses to chronic health disorders, and personal issues with chronic health disorders. So to start with chapter 10, talking about pain. So, as uncomfortable as pain is, it's significant for our survival and our ability to lead a healthy and full life. So, we often view pain as kind of a nuisance, something we wish we didn't have to deal with, but it has a function. So, pain is trying to tell us something. Pain provides low level feedback about how our body is functioning. So this applies to everything from a broken bone to even just an ache from sitting in the same position for too long. So pain is very important medically as well. And really it's because it's a symptom that's most likely to lead a person to seek treatment. So without pain, a lot of us would take a lot longer to seek medical treatment that we might really need. So pain can also complicate illnesses and hamper recovery from medical procedures. Further, pain can be complex, so it can accompany a range of both medical problems, physical problems, psychological problems. The relationship between severity of pain and severity of the problem may be weak, so this can really complicate things. So, for example, an agonizing injury can be relatively minor, and yet a painless lump can be indicative of something life-threatening. So, the degree of pain we experience isn't always related to the severity of the issue. So, pain has both psychological and medical significance. On average, pain is what people fear most about illness more than any other consequence. Inadequate relief from pain, too, is one of the most common reasons for patients to request euthanasia or assisted suicide. So, understandably, there's physiological aspects of pain production, but the experience of pain and how we interpret that pain is fundamentally psychological. The degree to which pain is felt depends on many factors. First, how the pain is interpreted. So someone may consider a pain to be unbearable, and another person considers the same pain to be irritating but minor. So for example, if you ask one person how it felt to get a tattoo, and they might say they barely made it through, and the other person may say, well, it felt kind of warm, it felt kind of tickly, but it was fine. Second, the context of the pain experience plays a role. So when is the pain happening? A good example is athletes. So many athletes have sustained an injury during the course of a game, but don't realize its severity or even notice that they're in pain until after the game is over. And if you think back to your sympathetic nervous system, one reason for this is sympathetic arousal. So you can't exactly be in agonizing pain when running away from a bear. So sympathetic arousal diminishes our sensitivity to pain so we can get away. So when there's sympathetic activation during a game, they are less sensitive to pain. So if any of you are, sports fanatics, I can remember finding out that in NHL, John Tavares broke his finger. And I don't know, but it's possible that he didn't even realize that his finger was hurting until the game was over because you're so focused. So culture also plays a role in pain experience, and this might even extend to those athletes and things where that culture is just to stay focused and get through. Some cultures, on average, thinking of more like ethnic groups, report pain sooner and react more intensely to it than other cultures. So your text discusses cultural perspectives on childbirth. And the example they give is how Mexican cultures believe that childbirth is a sorrowful, painful experience, so people fear it, and this enhances their experience of pain. In comparison, Yap culture views childbirth as an everyday experience. So this kind of impacts people's anticipation of childbirth as just something they go through and then they go back to their regular life. So, cultural beliefs of pain impact how people anticipate and respond to pain and the experiences that may result in pain. And lastly, gender plays a role as well, with women showing greater pain sensitivity than men. And this could be due in part to the cultural norms again, and the expectation for men to withstand pain and not admit to being in pain. So, measuring pain, understandably, is very important, and yet it is quite difficult. So, one barrier is the difficulty people have of actually describing pain objectively. So, one person's pain that they consider to be a 5 out of 10 might be a 2 out of 10 for someone else, and it might be a 9 out of 10 for another person. So, it's really hard to get an objective measure of pain. But one method is to use our large informal vocabulary that we have to describe pain. So, for example, a throbbing pain can be conceptualized as quite different than a constant ache or a shooting pain or a stabbing pain. And pain questionnaires have been developed to assess the nature of pain. So whether it's shooting versus throbbing, etc., how intense it is, its psychosocial components, so how much fear it causes, how much it's impaired someone's life. So these measures are really useful in a research sense and for a practitioner to get a wide variety of information about a specific client's experience with pain. And in neuroscience, methodological tools have been used to give valuable information about pain from the neurological side of things. So, for example, people with chronic pain disorders show loss of gray matter in brain regions associated with the processing of pain. So this information is really useful for mapping and understanding the prognosis of pain disorders, so what to expect long term. And this is especially true for progressive and chronic disorders like fibromyalgia. And lastly, pain can be measured by looking at pain behaviors, which are behaviors that arise from chronic pain, like changes in posture, expressions of distress like grimacing, and avoidance of activities because of pain. Pain behaviors are really useful to assess how pain has disrupted a person's life and can be useful to define the characteristics of different kinds of pain syndromes, so what different pain syndromes look like. So, as stated, the experience of pain may be fundamentally psychological, but there's definitely a physiology of pain. So the physiological experience of pain is protective, and it's trying to bring tissue damage into conscious awareness. Without this conscious awareness, we may not know that our body is sustaining damage. So imagine accidentally putting your hand in boiling water, and you have no knowledge that your body is now sustaining first, second, third degree burns because you're not getting any of those signals. So pain is accompanied by motivational and behavioral responses, such as withdrawal, like getting your hand out of the boiling water, and then intense emotional reactions like fear, crying, anger, if anyone stubbed their toe and then started swearing because they're pissed off. Lastly, there are verbal and nonverbal communications to others, which can either soothe or enhance the pain experience. So, emotional factors play a large role in the experience of pain, and it can, make it better, make it worse. So, for example, negative emotions can definitely exacerbate pain, and, on the flip side, pain can exacerbate negative emotions. So, there's 3 general kinds of pain perception, or nociception, and these have been distinguished in a lot of pain research. Firstly, medical nociception refers to pain resulting from mechanical damage to the tissues of the body. So, for example, if you've cut your skin or if you broke or crushed a bone. Thermal damage, as the name suggests, is experiencing pain from temperature exposure. Now, this can be heat or cold, so, like frostbite. And then lastly, polymodal nociception refers to pain that triggers chemical responses from tissue damage. So a primary theory in understanding how we experience pain is the gate control theory. And according to this theory, nociceptors in the peripheral nerves sense injury, releasing chemical messengers to the spinal cord. Like, hey, there's an injury over here, the finger is too close to the match and it's getting burned. So that message is passed directly to the reticular formation and the thalamus and into the cerebral cortex, which identifies the site of the injury, like we have an injury, this is where the injury is, and then sends messages back down the spinal cord to react. So it goes up to find out that, my finger's burning, now I'm gonna let myself know to pull my finger away. So 2 major nerve fibers are involved in pain perception. First, A delta fibers are small myelinated fibers that respond to mechanical or thermal pain. And these transmit sharp, brief pains rapidly. So when you really hurt yourself and it's like, ow, 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 ow. In comparison, C fibers are unmyelinated nerve fibers involved in polymodal pain, and these transmit a dull aching pain. So if you think about myelination here, it's increasing the speed of transmission, which is why the sudden and intense pain is more quickly conducted than the dull aching pain. Now, another area involved in nociception is the periductal gray in the midbrain. This area has been tied to pain relief when it's stimulated. So neurons in this area connect to the reticular formation in the medulla, which makes connections with neurons in the substantia gelatinosa of the dorsal horn of the spinal cord. So sensations are modulated by the dorsal horn and by downward pathways from the brain. So these are important for the interpretation of the pain experience. Now, pain sensation, intensity, and duration interact to influence the experience of pain, its perceived unpleasantness, and the emotional responses through a central network of pathways in the limbic structures and the thalamus, which then direct their inputs to the cortex. So, cognitive judgments are a large part of pain experience, meaning the cerebral cortex is involved in judging, is this painful? How painful is it? What should I do? So this includes judgments of what the pain means, which impact emotions experienced during pain, and these emotions can either make it better or make it worse, like I can do this or I'm scared. All of this is coming from that cerebral cortex, a higher order functioning. So clearly pain has a massive neurological basis. The brain controls the amount of pain an individual experiences by transmitting messages down the spinal cord to block the transmission of pain signals. Pain suppression is engaged using endogenous opioid peptides. So when you hear opioids, you may think of opiates, which include things like heroin and morphine and are pain control substances manufactured from plants. In comparison, opioids are opiate-like substances produced in the body, making a neurochemically balanced pain regulation system. However, the system obviously isn't in effect 24/7 because most of us don't always need to regulate pain, so it must be triggered. And stress is one factor that can trigger this system. So if you recall that the sympathetic nervous system is triggered by threat, like by stress, and this can result in reduced sensitivity to pain. So stress-induced analgesia is an example of this, where acute stress reduces sensitivity to pain. Now, as we know from previous chapters, there are 2 main forms of pain, acute pain and chronic pain. Acute pain results from specific injury that produces tissue damage, like a broken bone. Now, this pain usually can be cured and disappears when the injury site is repaired. Acute pain is usually short in duration and lasts 6 months or less. But in comparison, chronic pain typically begins with acute pain, but doesn't decrease with treatment and or the passage of time and exists for 6 months or more. Now, within the category of chronic pain, there are 3 main forms. Chronic benign pain persists for 6 months or longer and is mostly unresponsive to treatment. So the severity of pain may vary and can involve several main muscle groups. A common example of this would be chronic back pain. Recurrent acute pain refers to intermittent episodes of pain that are acute in character but chronic in condition, in that it recurs for more than 6 months. So it comes and it goes for more than 6 months. An example of this would be migraine headaches. You don't always have a migraine, but it's chronic in that for 6 months or more, you're getting migraines. And lastly, chronic progressive pain refers to pain that persists longer than 6 months and increases in severity over time. So on average, this is associated with malignancies or degenerative disorders like cancer or rheumatoid arthritis. Now, an important distinction with chronic pain is that it doesn't need to be present at every moment. So someone with chronic pain can have pain-free periods. However, the pain is present more often than not and requires a person to adjust their lives to accommodate the pain. Now, distinguishing between acute and chronic pain is important. Acute and chronic pain have different psychological profiles. Chronic pain often carries an overlay of psychological distress, which is complicated when you consider diagnosis and treatment, and the psychological ramifications that result from living with chronic pain, like depression, anxiety, anger, can further complicate things. Secondly, chronic pain patients can develop well-intended but maladaptive coping strategies to manage the pain. So things like withdrawing socially or catastrophizing their illness to ensure that they're accommodating their pain. So, for example, when someone's endured pain for a long time, it's easy to imagine that the pain will only get worse and there's no hope. But these beliefs can magnify the pain and just cause further distress. Also, chronic pain involves a complex integration of psychological, physiological, social, and behavioral components, more so than with acute pain. So this is important because other factors may help reinforce and maintain the chronic pain and the pain behaviors. Things like well-intending individuals who are trying to give care, attention, and support, but may unintentionally remove any reinforcement to try and return to normal behaviors and reduce the pain. Now, a common issue is a lack of pain control techniques for chronic pain. Although most pain control techniques work well for acute pain, they are less effective for chronic pain. Further, chronic pain management requires individualized techniques, resulting in more complex care and potentially more time spent without relief as a patient and their provider work to find a reasonable treatment plan. So, the profile of a chronic pain patient is different than that of an acute pain patient due to the complexity and the long-term consequences of chronic pain. Unlike acute pain, chronic pain is usually treated with a variety of methods, and this may result in a bit of a guess and test approach as a patient works with their provider and or on their own to find the right combination of treatments to address their needs. So as a result, people may experience inappropriate prior treatments, misdiagnoses, and or inappropriate prescriptions that can exacerbate the pain or even just add other side effects before someone arrives at a more useful treatment for them. Now, understandably, chronic pain impacts a person's lifestyle. By the time a chronic pain patient is adequately treated, the pain experience usually has become an integrated part in their life, which makes it more difficult to modify. Chronic pain patients may leave their jobs, may quit leisure activities, withdraw from loved ones, all to accommodate their pain. And because of job loss and reduced income, their standard of living may decline, and they may require public assistance more. So, as you can imagine, this can result in a loss of self-esteem and mastery and self-efficacy and an ability to be an independent person. And their lifestyle may become oriented around their experience of pain and treating the pain. Now, on the other hand, assistance and compensation for pain may actually reinforce the pain and the pain behaviors. Now, this could be conscious, like as someone may view it as manipulative, and more often than not, it's more subconscious because there's an incentive being provided for being in pain. So, for example, whether it's financial or support or whatever, compensation can increase the perceived severity of the pain and the extent to which it interferes with daily life. So, for example, I'm in so much pain, I don't think I can go grocery shopping, so I get someone to do it for me, and because they'll do it, it reinforces that I really do need them to do this for me. So, chronic pain also can take a toll on relationships, and whether they be familial, romantic, platonic, professional, etc. Chronic pain patients may not communicate well. It's pretty hard to communicate when you're in pain a lot, especially when you factor in the emotional reactions to the pain. And more often than not, sexual relationships completely deteriorate. Supportive spouses or other relationships, similar to compensation for pain, supportive others may inadvertently maintain the pain due to reinforcement and trying to be supportive, so allowing the pain behaviors to continue. Now, chronic pain often results in various pain-related behaviors that can maintain the pain experience. So, for example, chronic migraine sufferers may avoid bright lights or loud noises to prevent migraines or to manage one when it's there. So these alterations may become part of the pain problem and may interfere with successful treatment. So with that example again, you may anticipate pain if you reintroduce noise or light. So successful treatment may require you to introduce those so you can get back to a better quality of life and a more normal life. But you may be resistant because of the expectation of pain and this might amplify any pain you experience. Thus, having a good understanding of what a person's personal pain behaviors are and knowing whether those behaviors persist after treatment are important to treat the whole pain experience. So, understandably, no one likes being in pain, and pain control is important for both acute and chronic pain. Pain control can mean different things. So it could mean that the person no longer feels anything in that area that once hurt, pain or otherwise, or maybe feels sensations but not pain, like maybe pressure but not pain, feels pain but the pain is less than it was before and now they can tolerate it, or feels pain but is just no longer concerned about it. So it means different things depending on the situation. So some pain control techniques can be effective by just reducing feelings altogether in that area, like spinal blocking agents, or reduce pain to sensation but not pain, so things like sensory control techniques, or may work to teach patients to tolerate pain more effectively but not necessarily change the pain itself, so things like psychological approaches. So a primary method of pain control is pharmacological control, so using drugs, using medication. Any drug that influences neural transmission is a candidate for pain relief. Local anesthetics can impact transmission of pain impulses from the peripheral receptors to the spinal cord. So for example, applying an analgesic to a wound. If you've ever gotten stitches, if you think about how they freeze the wound before stitching it up so you don't feel what's going on, that's blocking the pain receptors from getting to your brain. Another method is spinal blocking agents, and another even involves acting in higher brain regions like antidepressants. So these can combat pain by impacting the emotional response, like reducing anxiety and improving mood, because we know those can enhance the experience of pain. Additionally, these can impact the downward pathways that modulate pain, so pain is interpreted as less severe and interpreted as more tolerable. However, there's significant concerns with pain medication. So one issue is undesirable side effects of medication, like an inability to concentrate, even drug poisoning if there's an interaction effect with other meds, or if the body just doesn't metabolize it well. Nerve blocking agents can also produce side effects like paralysis in the limbs, loss of bladder control, and many result in the pain returning after a short period of time. So it can be quite upsetting side effects, and the pain may still come back. And another big concern is addiction. So for example, morphine is a very effective painkiller with a high rate of tolerance and a high rate of addiction. So the concern over addiction can lead to undermedication, which can perpetuate pain behaviors and stress and disability. So another option is surgical, which, as it sounds, is a much more extreme method of pain control. Surgical pain treatment involves cutting or creating lesions in the pain fibers at relevant areas of the body to stop the conduction of pain sensations. Other surgical techniques may disrupt the transmission of the pain from the peripheral areas to the spinal cord, or interrupt the flow of pain sensations from the spinal cord to the brain. So it's trying to disrupt the roadmap, basically, to interpret the pain. Although extreme, and it can be successful in a lot of cases, effects may be only temporary, so pain may return. And these procedures can be very expensive and could even result in permanent damage to the nervous system, which ironically could possibly result in additional chronic pain. So as a result, surgical treatments are usually viewed as a last resort option, and even in those cases, the benefits don't necessarily outweigh the risks. So another method is sensory control using counter-irritation. And this is one of the oldest techniques of pain control, where you inhibit pain in one part of the body by stimulating and or mildly irritating another area. So you may have done this, or you may find yourself in this situation to try it. If you hurt one area of your body, try using counter-irritation by pinching or scratching the area near the part that hurts. So this technique is usually effective only in the short term, because obviously the effects of the pinch won't stay forever. And it's usually seen as either effective for acute temporary pain or as a repetitive part of a regimen for chronic pain. Because obviously for chronic pain, you'd have to keep doing it over and over again. So recent efforts to control chronic pain have incorporated also exercise and other methods of increasing mobility. So we used to believe that activity should be reduced to protect someone with chronic pain. Like if you have back pain, you don't want to be moving around too much and you don't want to aggravate it. However, research suggests that regular activity is necessary to maintain functioning and to maintain the health of your bones and your muscles in your body. Otherwise, the body could lose its muscle memory, its ability to tolerate activity without pain, because the more you restrict yourself, the harder it will be to get back there. Psychological control of pain involves actively having the client participate in their own care and have them do a lot of self-monitoring and learning about their pain, triggers for their pain behaviors, and how those either alleviate and or reinforce the pain, how others might reinforce the pain behaviors. So these methods are generally most effective for managing pain that can be anticipated, like slow rising pains, chronic pains that they can plan for. In comparison, sudden unexpected pains that aren't necessarily planned in advance, these don't really work for, because you don't know what you're planning for. And with distraction. So if you go back to the discussion of complementary alternative medicine in Chapter 9, remember that much of the benefits of CAM could possibly be attributed to the distraction that it provides. So like with acupuncture, you have needles in various parts of your body that can serve as a distraction from maybe lower back pain or something. Distraction with pain involves turning attention away from pain either by focusing attention on an irrelevant and attention-getting stimulus and or distracting oneself with a high level of activity. So if you remember that greater attention is placed on symptoms, or the greater attention placed on symptoms, the more intense those symptoms may seem. So this can apply to pain as well. So distracting may be beneficial to redirect that attention away from the pain. So one method is to focus attention on another activity, like reciting a poem or a song when attempting to withstand pain. So if you're getting a tattoo, chatting with a friend or something to divert your attention. Another method is to focus on the events directly, but then try and reinterpret the experience. So the example given in your book is of a young child talking about a painful dentist experience and trying to treat it like it's a secret agent interrogation. Overall, distraction's most effective, again, with acute pain and less so with chronic pain because of mostly practical limitations. So people can't distract forever. So with chronic pain, they'd have to be distracting like for a significant period of time. Also, it doesn't treat the pain, so the pain is still there. So it may be more effective when combined with other treatments. Now, lastly, I'll discuss pain management programs. So recent efforts have led to the development of pain management programs, which are coordinated efforts to treat chronic pain. And these bring together interdisciplinary efforts using neurological, cognitive, behavioral, and psychological expertise to treat the entire pain experience. So this begins with an initial evaluation, which has quantitative, like numbers and data, and qualitative, like interviews, words. Both assessments of the pain, its location, its sensory qualities, its severity, duration, onset, history. Further, there's a functional status assessment to see how the person's functioning right now compared to how they were before, and the degree to which the pain has impacted their life. After the initial evaluation, there's an individualized treatment program developed for that person, and these are usually structured and time limited with concrete aims, endpoints, rules, so the patient and their team have concrete goals to work towards. The first component of the program is patient education. So education may include talking about the medications, what they're supposed to do, any side effects, social skills training to, maybe ask for help, maintain boundaries, assert your needs around your pain, dealing with sleep disturbance, which is really common, psychological consequences of pain, so depression, anxiety, etc., non-pharmacological measures of pain control, posture, weight management, diet, exercise, how all these things contribute to pain management. So most patients are trained in a variety of methods using the knowledge from all these different areas to control pain, because that way, like, one thing doesn't work for everyone. So the more skills you give them, the more tools in their toolbox they have to choose from to deal with their pain. So these can include all the things just discussed, and then things like relaxation techniques, exercise, coping skills, the psychological things, distraction, etc. Group therapy is a very common part of pain management programs to help patients regulate and understand their emotional responses to pain and identify any problematic thinking patterns that can exacerbate pain. So if you go back to like prefactual thoughts, like thinking this pain will be here forever, I can't overcome the pain, things like that could get in the way. So because people with chronic pain often withdraw from their social circle, efforts from family to be supportive can accidentally influence and reinforce the pain behaviors. So family are often involved in these pain management programs to educate the family and the person on how support of others can help in an effective manner that doesn't exacerbate the pain experience. And lastly, like any health intervention, relapse prevention is included to ensure that people won't return to previous pain behaviors. So this can include problem solving too, for times that it can be easy to slip back in. So that concludes my coverage of Chapter 10. Now moving on to the first chunk of Chapter 11, talking about managing chronic health disorders. So if you recall all the way back from like chapters 1 and 2, chronic disorders are now the greatest cause of death, overtaking acute disorders. At any given time, 50% of the population has a chronic condition, and the management of chronic conditions is very expensive, accounting for 3/4 of the US's health spending. Chronic conditions can range from things like partial hearing loss, maybe more minor chronic conditions, to life-threatening illnesses like cancer and diabetes. And if you recall, they can be present from birth, like someone being born with asthma, perchance, to things that were developed because of like lifestyle factors like type 2 diabetes. So when we talk about the management of chronic health disorders, a big topic that comes up is quality of life. And until recently, quality of life wasn't really considered an issue of medical importance because it doesn't immediately relate to treating and curing the illness. It's either we're going to keep the patient alive, not as much concern for what the life will be like that they'll have. However, especially as more and more people live with chronic conditions, understanding how to maintain quality of life is ever more important. If you go back to the comparison of morbidity versus mortality, how effective would it be if no one died and everyone lived forever, but everyone was sick and no one had a quality of life? So, assessments of quality of life measure the extent to which a patient's normal life activities have been compromised by disease and by the treatment for the disease. So, quality of life has several components: their physical functioning, their psychological status, their mental health and well-being, social functioning, and disease and treatment-related symptoms. So when researching quality of life, researchers focus on how much the disease and the treatment interfere with the activities of daily life. And this may be everything from eating, sleeping, work, etc., to among the more severely ill, like maybe their ability to go to the bathroom or dress themselves. So there are several main reasons for studying quality of life. First, by documenting how health disorders impact daily living, interventions can be designed to improve the quality of life when faced with health-compromising illnesses. So see what you're up against before you can develop interventions to deal with those things. Secondly, measuring quality of life is helpful to pinpoint problems that could emerge for people with specific health issues. So this way, both the patient and practitioner have an idea of what to expect and can come up with plans to deal with that. Next, quality of life measures can be used to assess the impact of treatments. So many treatments may be absolutely necessary to treat an illness and may be completely successful at treating an illness, but can damage quality of life along the way. So for example, a cancer treatment may have poor survival rates and can demonstrate significant damage to quality of life. So if that's the case, then the treatment may be regarded as more harmful than the disease. Like it's not very effective at treating the cancer and people have a crap quality of life. Fourth, quality of life information is used to compare therapies for secondary effects. So if two therapies are equal in their ability to treat the condition that they're supposed to treat, then the next tier is how's quality of life on these things. So for example, if there's equal survival rates, but one substantially lowers quality of life, the other one may be regarded as the treatment of choice because they're both going to take care of the condition, but you'll actually have a much better quality of life with this treatment than this one. And lastly, studying quality of life can be used to inform healthcare practitioners about which methods will maximize health and give them the highest quality of life. So giving the best kind of care for your patients. So, moving on, a diagnosis of a chronic health disorder is laden with emotion, understandably. A patient could be left in a state of crisis, like their whole life is changing and is shifting, and the coping styles that they have at time of diagnosis, if they're not enough to resolve those problems, this can result in an exaggeration of the symptoms, increasing negative attitude, and just overall worsening health. So, a lot of chronic health disorders come with a lot of uncertainty and ambiguity. You don't really know what the future holds anymore, know what to expect. And this can negatively impact health in addition to the actual condition itself, and could result in a lot of different emotional responses. And three of the most common ones are denial, anxiety, and depression. So, denial is a defense mechanism by which people avoid the implications of the disorder. And a good way to think of defense mechanisms in general is there's probably a very childlike, easy example to look at. And then the defense mechanism in adults is obviously a much more sophisticated, mature version. So with denial, a basic example would be, the kid that says they didn't do that when they clearly did. Like they didn't eat the cookie even if they have crumbs all over their face. Denial in adulthood is obviously much more sophisticated and mature than that, but nonetheless, the foundation is still there, that you're avoiding something that's right there. So it's a very common reaction to chronic health disorders. People may act like the issue isn't that severe, it'll go away, there'll be few consequences, it's no big deal. And immediately after diagnosis, this could actually be protective because as a function of defense mechanisms, the goal is to protect you from pain. So it can be protective initially, especially if you're not ready, physically, psychologically ready to come to terms with the condition. It can protect you from having to do that before you're in a state that you can. However, over time, the costs of denial can override the benefits because it can interfere with engaging in the needed treatment and absorbing the treatment information, which can compromise health. Now, anxiety is also very common after diagnosis of a chronic health disorder. So patients may become overwhelmed by the potential changes in their lives and possibly the prospect of dying, depending on the condition. And anxiety is particularly high at certain times, like when you're waiting for test results, when you first receive a diagnosis, when you're awaiting an invasive medical procedure, like maybe a surgery, and when you're anticipating or experiencing crappy side effects of treatment. So anxiety is a problem because it's inherently distressing itself, but it also can interfere with treatment. So if you remember about Janice's experiment, that high anxiety people coped poorer with the surgery afterwards and were unable to understand the aftercare instructions. So too much anxiety can be overwhelming and you can't take information in. Also, symptoms of anxiety can distort the disease profile, and possibly symptoms of anxiety can be mistaken for symptoms of the actual disease that's causing the anxiety, which can interfere with assessment and treatment. And lastly, depression is another really common reaction, with up to 1/3 of medical inpatients with chronic illnesses reporting symptoms of depression. Depression is particularly common among patients with cancer, heart disease, people who've had a stroke, and people who have more than one chronic condition. Further, there's medical issues related to depression. So depression isn't isolated to an emotional experience. And recall that depression can predict death by all causes. So depression can also increase the likelihood of contracting chronic conditions like dementia, heart disease, stroke, and then it can exacerbate existing illnesses. Depression can also complicate treatment adherence and medical decision making, and can interfere with a patient's ability to adopt their role as like co-manager of their care. So, kind of like with anxiety, there are a lot of symptoms that can come with depression that can exacerbate or complicate the presentation of their illness. And a common symptom of depression can be hopelessness or lack of motivation to do things. So, adhering to your treatment and becoming an active participant in your treatment can be difficult if you're so depressed you just don't see the point. So, understandably, assessing depression in the chronically ill is very important, and because of course it can be very complicated because the symptoms of treatment and the symptoms of the chronic conditions and the symptoms of depression can overlap. So, for example, fatigue, sleeplessness, weight loss, these can all be symptoms of depression, but they can also be symptoms of a chronic condition or treatment for a chronic condition. So, you need to tease out what these are symptoms of, because if these symptoms are attributed to either the condition or treatment, the depression can go untreated. And vice versa, if it's a symptom of depression, but it's being interpreted as a symptom of the treatment or the condition, it can impact successful treatment. Now, not everyone with a chronic health condition will become depressed. On average, depression increases with the severity of the health condition. So if it's a chronic condition that's going to progress and end in death, a higher likelihood of depression from that compared to a more manageable, less interruptive chronic condition. Also, people who have increased pain and disability from the condition have a greater likelihood of experiencing depression, or people who are experiencing other negative life events at the same time, or who don't have social support are more likely to be depressed. So, taken together with all these emotional responses, being aware of them, recognizing them, and addressing them is imperative to preserve quality of life and adequately treat a disorder. And so the last topic in the second part, or this first part of chapter 11, is personal issues in chronic health disorders. So having a chronic health disorder can have a lot of external cooperative issues, but to fully understand having a chronic health disorder, you need to consider the personal self, because it really is a very personal internal experience. So the whole self, sources of resilience and vulnerabilities. In psychology, a prominent term is self-concept. So this is a stable set of beliefs about yourself and your personal qualities. Now, relatedly, self-esteem is what we use to evaluate our self-concept, which refers to whether or not you evaluate yourself as either good or bad, having redeeming qualities or unredeeming qualities. So the self-concept is a composite of self-evaluations regarding all sorts of aspects of our life, which can include things like body image, achievement, social functioning, and the private self. So body image is the perception and evaluation of one's physical functioning and their appearance. So with chronic disorders, there can be a lot of physical impacts on the body, whether it's a specific part of the body or the whole body. But with chronic health disorders, if there's a more isolated affected part, that one can be evaluated very negatively, and or the entire physical body can be viewed with a negative connotation. So body image is something that can be quite stigmatized against and have a lot of stereotypes, a lot of assumptions, but there's significant issues for people with chronic health disorders when it comes to body image. Because poor body image can increase risk for depression and anxiety, which, as you should know by now, have a lot of implications for chronic disorders, chronic pain. Also, body image can influence whether a person adheres to treatment fully or creatively, and their willingness to, again, adopt that co-management role and be an active participant in their own care. So, for example, treatment which results in undesirable physical alterations may be met with a lot of resistance, so like losing your hair from chemotherapy. With achievement through vocational and avocational activities is a very important source of self-esteem and your self-concept. So a lot of people get a sense of purpose, a sense of who they are, and their drive in life from their job, from their career, or from their hobbies, their leisure activities. So if a chronic health condition threatens any of these areas, the self-concept can be really damaged. You can kind of lose a sense and purpose for life. Like, what do I do now? However, the reverse could be true as well. So if work and hobbies aren't threatened by health issues, but possibly other areas are, the patient can use these sources of satisfaction to protect their self-concept and possibly create new areas of achievement and new areas of self-concept. With social resources, so like family, friends, these are really valuable for information, help, emotional support. So if you think back to the chapter on social support and the types of social support, so a breakdown in these areas can definitely impact all areas of life. And fears about being abandoned by others is probably one of the most prominent concerns of people with chronic health issues, like being a burden. People won't be able to deal with this. So to combat this, family and friend participation in health disorder management is actively encouraged. And lastly, the idea of the private self, so that core of a person's identity. So their goals, their ambitions, their desires for the future. And understandably, a lot of these can be impacted by chronic health disorders. And adjusting to a disorder can be impeded because a person has lost an unrealized dream. So for example, someone who always wanted children, who finds out they can no longer have one. So this is, as it is named, a very private part of someone's experience. But encouraging someone to talk about these losses, disclose these losses, and the difficulties and the emotions they're experiencing can be really helpful to help them, first of all, be aware of the impact of these losses and help them reveal even alternative paths to fulfillment and new dreams and goals to realize. So that concludes the first part of chapter 11. And in the next video, I'll go over the second part and I will go over chapter 12. And then I think for 13, 14, and 15, it's just one chapter a week. So keep it short and sweet as we round out this 12-week course. All right, if you have any questions, you can always email me. Otherwise, take care.